Hi, good afternoon, everyone. This slide sort of is a continuation of the talks we've heard previously, and our work, along with others, have tried to add to the clinical narratives that you all are seeing, patients respond to therapy, patient relapses, to add the genetic narrative. What happens in terms, from the evolutionary perspective, when we treat patients and they relapse? And this slide sort of is at the heart of the work that I'll present today, that if you take enough intrapopulation, intratumoral diversity, heterogeneity, applied to its strong selection pressures in the form of effective therapy, what you get often is evolution of the disease to more aggressive and resistant form. And in this sense, cancer evolution is a central obstacle to curative therapy. So we study this in the context of chronic lymphocytic leukemia, which is a good place to look at it clinically, because for a long while now, and this is indeed improving with this latest targeted agents, we do have effective therapeutic options. So we are able to impact the evolution of disease because we are able to apply strong selection pressures. From the research perspective, the facile access that we have to primary tumor cells dynamically over time, we can obtain them directly from the patient's blood, and we can do this dynamically over time, allowing us to study the evolution of the disease in its natural environment. So this work is based on a large body of knowledge over decades that have shown that what was previously considered as a monolithic, clonal, uniform entity, all cells are identical, is actually composed of an admixture of subpopulations. Within each patient, we're challenged to treat not one disease entity, but rather thousands of variations of this disease. And these challenges are therapeutic because they have to deal with so much variation within each individual patient. We first applied whole exome sequencing to start understanding the genetic complexity of this disease. And just to provide a little bit of background, what we do is we use whole exome sequencing to obtain the allelic fractions, how prevalent is a mutation within the entire DNA, and then we algorithmically, using computer programs, we then convert this to cancer cell fraction, which essentially asks, if I have 100 CLL cells, how many of them contain, for example, the Notch1 mutation or a TP53 mutation. Once we have that type of insight, we can then try and dissect the evolutionary history of the disease. We can ask what event comes first and what comes later when we look at cohorts of patients. And for that, we look at large cohorts of patients that undergo whole exome sequencing, and we try to see which mutations are commonly seen as clonal, meaning that they're in all cells of the populations. And those are the ones that you see here. Those are the ones that you see here on the left. Those are mutations that are probably ancestral, very early. They're transforming mutations. They happen early in the disease, whereas the ones that are often seen here late are those that are acquired late in disease evolution. And the idea is that if we are able to expand this, we will be able to build predictive models that would help us look at the genomic profile of a given patient and try and predict forward what would be the evolution of this disease. And then we can expand this with larger cohorts to kind of come up with these predictive maps that would allow us to assign probabilities not only to what is going on now genetically, but what is going to happen in the future. We can also study very closely the relationship between treatment and clonal evolution. And here you have examples where we look at the cancer cell fraction at time point 1 and time point 2. We see an example where there's almost no evolution, even though these two samples are 3 or 4 years apart, whereas another example where you have one subclone here with a SF3B1 mutation increasing in size. And what we observed is then when we look at patients that had again, 3 or 4 years apart. We sample their exomes, their genomes, 3 or 4 years apart. They have very little evolution, whereas the ones that do have treatment in the interval, those that are treated during those 3 to 4 years, tend to have very frequent evolution. And that suggests that our therapies, by applying these strong selection pressures, are accelerating the evolutionary process. It also helped us see that in many cases we can find those clones that are taking over the relapse disease already in the pre-treatment sample. Can it impact clinical outcome? So in 2 independent studies, what we've seen is that if you look at the pre-treatment diversity of CLL, how many clones are there before therapy, that is associated with adverse outcome in this disease. So in summary, we can use these type of methods to look at bulk sequencing from a patient and then identify clonal versus subclonal mutations. We can use this to infer the evolutionary history of the disease. We can track its evolution with therapy, and hopefully we can predict the evolutionary outcome with therapy as well as the clinical outcome. I'll skip this. So again, and the other insight is that if we look at pre-treatment diversity, then pre-treatment diversity is associated with adverse outcome. What about relapse CLL? So one of the studies that we have performed, we compared the genetic makeup of the disease before therapy and at relapse. And we saw that in the context of, this is in the context of fludarabine-based therapy, clonal evolution with therapy is the rule rather than the exception. All but 2 patients experienced significant clonal evolution when we compare the pre-treatment and the relapse. And this is important because it means that if a patient comes to you to the clinic, we should not base your clinical decision-making based on genomics profiles that were obtained, for example, at diagnosis, if there was a therapeutic intervention in between, and I think that's important to keep in mind. The other question that it brings up is, what are the quantitative dynamics that allow this phenomena to happen? So here we have a pre-treatment clone that is replaced by a relapse clone. And we want to start understanding, dissecting the quantitative mechanics that allows one clone to gain the race compared to another. And we can consider, for example, a couple of scenarios. Here we have one scenario, perhaps the one we think about more commonly, of selective resistance. Some cells are resistant to the drug. They hang out, they're able to survive the therapeutic attack better and repopulate and gain in relapse. Another example is you have here an alternative model where actually all cells are equally sensitive to the drug, and what allows one clone to win the race, so to speak, is its ability to regrow back faster, to repopulate faster. So how can we get at those type of questions? And this is together with the German CLL study group. What we have done is we started off with these results that I showed you before, where we compared the pre-treatment and the relapse using whole exome sequencing. We saw again that in all but 2 patients, those genetic profiles were significantly different. And now to understand what allowed the relapse clone to take over, we tiled the interval between those time points with deep sequencing. And it requires some bioinformatics that allows us to use this data and to create these kind of phylogenies. But ultimately, what we get is something like this. So this is the panel, the results we had previously. We had pre-treatment and relapse separated by 6 years. We had a small subclone, SF3B1, that expanded in size over time. And now we ask the question, why did this clone win compared to that clone? And now with this deep sequencing tiling that time span, we can now answer these questions quantitatively. And here we see that actually both of those clones had the same reduction, the same sensitivity to the drug, and what allowed this SF3B1 clone to win the race was its ability to regrow back faster after therapy. And the nice thing is that when you can represent clonal growth mathematically, that allows us to rethink what would precision prognostication look like. Because now we can forward extrapolate in time the clonal growth pattern and make predictions regarding clonal sizes in the future. And by the way, this type of pattern where the sensitivity to the drug was equal between the two clones, the pre-treatment and the relapse, what allowed the relapse clone to win the race with its ability to grow back faster was consistent in samples that did not have TP53 mutations. So in those samples, the reduction with therapy, the sensitivity was similar, and what allowed the relapse clone to grow, to dominate the relapse disease was its ability to grow back faster. In contrast, we have a different example. Here we have a p53 mutant that's growing in size over time, and here we see that it does indeed have reduced sensitivity. So in the case of TP53 mutants, it's both the reduced sensitivity and the faster regrowth probably that are contributing to why this mutation is so effective in taking over the relapse CLL population. We wanted to extend this also to the context of resistance to Ibrutinib, and now there's emerging data that in those patients that have resistance, it's often driven genetically. To do so, this is an example from a patient. You see the tumor burden is reflected through the white blood cell count, and you see sort of a lot of the things I reviewed before. The patient is treated with FCR, has a prolonged remission, and relapsed, treated with Ibrutinib, has another remission, and then relapsed again. And now through whole exome sequencing and deep sequencing, we can project on this clinical narrative a genetic evolutionary narrative. And what we see is that in all of those cycles of remission and relapse, we see significant clonal evolution. Again, if the patients come back to you with relapse disease, do not assume that the genetic makeup of the disease is identical to the pre-treatment makeup. Another thing is we can start dissecting the phylogenetic trees, and in this particular individual, we saw something that was interesting and now has been seen in other cases, is that actually that individual had 4 distinct clones, subclones, that had PLC gamma 2 mutations. And that just gives you a sense of the tremendous degree of heterogeneity, of diversity that is fueling the evolutionary process. There's enough clones there, multiple clones there, that they can all rise up together. And we confirmed through single-cell sequencing that are indeed sibling clones. So those are sibling clones that are present in this CLL patients and then are able to subvert the therapeutic attack with Ibrutinib. I described before that we can forward extrapolate mathematically to make predictions about the future. But we can apply the same principle and backward extrapolate over time to ask the question of what was the number of resistant CLL cells or CLL cells bearing the resistant variant on the day the patient took the first dose of the drug. And we can do this through back extrapolation. Once we have the growth rate, we can back extrapolate in time and try to ask the fundamental question of when we see resistant variants, are they already pre-existing in the patient's, in this case, circulation before they receive the first dose of the drug. And we came here with estimates in this particular patient that ranged with a frequency of 1 to 1 million cells or 1 to 500,000 cells already contain the PLC gamma 2 mutations. And we then went ahead and tried to validate those predictions experimentally, and we used this highly sensitive sequencing method that is based on emulsion droplet sequencing that basically allows us to screen through millions of individual CLL cells and to ask where are those resistance variants. And we see that the predictions that we made analytically using the mathematical back extrapolation were highly consistent with the measurement, and that tells us that at least in some cases, and also it's a formal demonstration of this, the resistance arises from pre-existing clonal diversity. The idea that we can now represent clone mathematically, extrapolate forward, extrapolate backward, motivated us to start doing this early in the disease course. Can we start doing this earlier in the disease course? And for this, we teamed up with Adrian Wissner and Jan Berger and start profiling patients treated with Ibrutinib at very high frequency early on in their therapy during the first year before any of them experienced any relapse disease. And you can see here the typical patterns. So they often experience a slight lymphocytosis early on, and then they all respond well in terms of the ALC count. And then we performed sequencing at all of those time points to see what happens genetically in terms of clonal evolution. And again, what we do is once we get those measurements, we have to algorithmically convert them into individual clones, convert them into measurements of individual clones over these time points. And what we saw was that in approximately half of the patients, despite the fact that all of them seem to be responding in terms of decreases in ALC, there are already differences in these responses in terms of different clones. So that means that this patient is, this particular patient does have a decrease in the ALC, does have a response, but the response does not affect homogeneously different clones. And that could be because of genetic characteristics of these clones. It could be that some of these clones are housed within more protective lymph nodes, and there are other sources of variation there. But the insight was that even within the first few months, we already see samples that do have this kind of clonal divergence. Some clones are responding better than others, whereas half of them seem to have almost no clonal variants. All clones are dying off at an equal rate. And what we have seen was that when we then try to ask whether this early clonal shifts, are they associated with adverse outcome, even in this kind of preliminary data, we see that already there's a signal that the presence of clonal shifts is associated with shorter time to progression. We've also had the opportunity to probe relapse disease, and the strategy we have taken was a lot of those patients were first tested with targeted sequencing of BTK and PLC gamma 2, which are the known variants that are associated with resistance to this disease. And then for those patients that did not have this data, we went on and performed whole exome sequencing and deep sequencing. And what we've seen is that, for example, some of those patients did have PLC gamma 2 variants, but they were not within the exons that are usually targeted with standard clinical targeted sequencing. And that tells us that even within those already identified genes, we may have not characterized fully the variants that are associated with the disease. Again, in this case as well, we can back extrapolate over time. We can make predictions regarding the number of cells that were present before therapy initiation. We had a couple of patients that did not have BTK or known mutations. It's about, I think the consensus in literature, that's about 15% of Ibrutinib resistance does not have these mutations, and we don't necessarily know what's causing it. In this case, again, we have seen a deletion 8p as a potential candidate. And we also had this opportunity to study patients with Richter's transformations, which, as you heard, is a fascinating topic and not understood biologically very well. In this particular instance, we have found a mutation with ITP-KB, which is seen in DLBCL, is not very commonly seen in CLL, and is downstream from the BTK target. So to summarize, I think what we're trying to suggest here is that there is a potential to integrate clonal kinetic in the future into clinical care. And what that will allow us to do is to create quantitative precision prognostication based on dynamic measurement. Instead of basing therapeutic decisions on a one-time genomic measurement before the patient is treated, we can now think of replacing this with a continuous measurement that would allow us to say which clones are responding less, and ideally that would drive closed-loop optimization, where we can use this information and adapt our therapy in such a way that would guide, for example, combination therapy, that, as you've heard, is a significant challenge in this disease. And I just want to mention that we are working to apply some of these methodologies using emerging liquid biopsy technology. I think of CLL as sort of the easiest liquid biopsy, but now in other lymphomas, in other malignancies, we're applying this using the ability to recapitulate some of what we're doing in CLL using liquid biopsy, primarily through cell-free DNA. I'm out of time. I'd like to thank many folks in my lab, the great environment at Weill Cornell, Rick Furman and John Allen and others, our CLL collaborators across the world, Stefan Stilgenbauer, Jan Berger, Adrian Wisner, the team at Dana-Farber, Jen Brown and Kathy Wu, and I don't know if I was supposed to show this. Maybe not. Oh, well. Anyway, thank you so much.